Development Committee. We thank everyone that was able to join today, and we thank our very precious Dr. Emlah Tubuo, who has been grateful for the last few years of being our star presenter, and we are honored that this year again she agreed to be our first speaker for this 2026 series of educational talk. So for those who don't know me, my name is Venice, and I am going to be your moderator for this first section in the next hour and a half. So a few house rules again, like Dr. Renadine said at the beginning. We ask that everyone mute themselves, and if you have any questions, refrain yourself from asking them during the talk. If you feel like you might forget them, you can enter them in the chat. Me and my team are going to check periodically, but all of those questions are going to be answered at the end. Also, we ask that like Dr. Renadine said, this session is going to be recorded for our archive so that we will be able to refer back to this for those who are interested. So if you do not want to be recorded, you are free, feel free to remove yourself or like remove your video. But it's always pleasant to see all of your beautiful faces, so don't be shy. Now going into the talk itself, I don't need to introduce Dr. Tubuo, but I'm going to do her justice and just remind everyone of a few of her accomplishments. Dr. Emlah Tubuo is an integrative pharmacist, entrepreneur, TEDx speaker, and advocate for whole person health. She is recognized as one of the leading national voices empowering pharmacists to discuss and integrate dietary supplements into their practice confidently. She has presented at major U.S. pharmacy conferences, including McKesson Ideas Share, APHA, NCPA, and Cardinal RBC. She also serves as a key opinion leader for FullScript, one of North America's largest supplement distributors. She has served as the Ohio Pharmacy Association's trustee for District 9 and currently serves as the Vice President of the Ohio State University Alumni Society Board of Governors. She also just launched her podcast, Intentional Living with Emlah, on Apple Podcasts and Spotify. So you are all invited to listen to the podcast and maybe ask her if you want to jump in and share also your experiences. Through her work with Powell Pharmacy, Dr. Tubuo, Emlah Naturals, and Intentional Living with Emlah, she equips pharmacists with practical strategies to navigate industry challenges, improve patient outcomes, and transform their practices into thriving, patient-centric businesses. Known for her engaging and inspiring style, both on stage and in her TEDx talk, she leaves audiences motivated, informed, and ready to elevate the care they provide. So a round of applause for our own Dr. Emlah Tubuo. So Dr. Emlah is going to talk to us today about a topic that has been a hot topic in the last few years. And the title of her presentation is Lipoprotein A, Apolipoprotein B, and cardiovascular risk in African and African descent population, which are two key molecules that are all most times overlooked when doing lipid panels. So I'm not sure if you were you knew about this, but 50 to 75% of people who have cardiovascular events have normal lipid panels. So Dr. Emlah is going to talk to us today about those two specific molecules and how we can be more involved in catching those and hopefully prevent cardiovascular events in African and African descent population. So Dr. Emlah, you want to take over?
I do. Let me move this over here. Okay. Well, I'm honored to be presenting to you guys today. Thank you very much. I think, what do we have? We have an hour, or what do we have, an hour or an hour? An hour, okay. I will do my presentation for about 30 minutes, 30 to 40 minutes, so that we can have about 20 minutes for discussion. We're 10 minutes in, but I'm glad to be doing this. It's kind of weird my virtual presentations are not my most favorite thing in the world because I just feel like I'm talking to myself, and it pains me when I talk to myself. I like to talk to people. I like people to talk to me back. But so you're just going to have to spare and bear the pleasure of listening to me just yap for 30 minutes. And then just take down notes and write down questions, because I prefer to answer questions so that way your 30 minutes is actually put into good use. And you're not just hanging out with me and I'm just talking about stuff that you're not getting. I'm going to try to make it as practical as possible. So I titled the slide "Two Numbers That Can Change the Plan," because we're looking at two numbers, Apolipoprotein B and LP little a, which is lipoprotein little a. So lipoprotein tiny a. And those are the cardiovascular markers that we're going to be talking about today. And I want you guys to pay special attention because these two disproportionately affect people of color, people of African descent, and people of South Asia. So that's the reason why we have all been there where somebody, the news is like, I'm in another WhatsApp group and they go, oh my goodness, this person was at the party yesterday and then today they have a heart attack. This person was healthy. Oh, they're fine. They're always working out. They have all the healthy habits and they had a cardiovascular event. What happened? So we're always thinking about that. And Dr. Venice just mentioned that 50 to 70%. I'm going to go ahead on the slide here. So I put a little bit of the objectives there so that way we have, as pharmacists, we kind of have to have it a little written down. So give me structure for my presentation. I will share the slides with Dr. Carol so that way she can share it with you guys. So that way you can have it written down if you need to refer to it. So the goal is to figure out, learn really what is Apo B and what is LP little a, and then how can we navigate cardiovascular disease with these at the back of our mind. 50 to 75% of individuals that have a cardiovascular event have normal LDL levels. And so when we talk about cardiovascular event, the first thing that comes to our mind is cholesterol, the traditional lipid panel, and then we look at comorbidities. We look at type 2 diabetes, we look at hypertension, we look at lifestyle, we look at all the other metabolic diseases that are out there, and we stack those on, but nobody mentions apolipoprotein B and LP little a. So that's why I want to bring your attention to it today. So what's happening to people who have a cardiovascular event and their lipid panels are standard. And a lot of these people are on a statin because most often statins are first line for cardiovascular disease, for cholesterol management. So let's take a look at your normal artery. Your normal artery is on my right on my screen, and it has a few LDL, VLDL, and ideal molecules. Nobody really measures ideal molecules, but we're looking at the lipoprotein, the dense lipoprotein. We're looking at how dense they are, and that's how we're looking at it. Small. I want to switch your mind and look at it from balls. Look at maybe a golf ball and a beach ball. So always think about it, because when we go and get our lipid panel tested, we get our HDL, LDL, triglycerides, total cholesterol, sometimes VLDL, and then ratios. So that's typically what people look at. You're looking at your good cholesterol, which typically people refer to the HDL as a good cholesterol and the LDL as a bad cholesterol, which technically no cholesterol is good or bad. They just term it good or bad because of what the cholesterol is doing. It's either taking cholesterol from the liver to the periphery or from the periphery back to the liver to be recycled. So that's why HDL gets the name the good cholesterol and LDL gets the name the bad cholesterol. But we'll focus a little bit on LDL today, and we'll look at all these LDL particles. We'll look at these particles, and they are of different sizes. So there are some that are like a golf ball, there's some that are like a tennis ball, and there's some like a soccer ball, and there's some like a beach ball. So always think about it. The way I teach students to remember it is always, would you rather, as an African person who doesn't play golf, would I rather be playing golf or would I hang out at a beach? I'd rather go to the beach. So that's how I look at it, that we want our particles to be bigger, our LDL particles to be bigger and fluffy rather than to be small and dense. So that's kind of how I remember it. So we want the particles to be bigger, because if they are bigger, the chances that they can sneak into the endothelium of the lumen and then hide inside the endothelium. I don't know. Can you guys see my mouse? I don't know if you can see my mouse. Okay. If they can sneak into the endothelium and hide in here, because they should be lying in here. But if they can sneak in and hide, look at this other one is clean and nice. That's a normal artery. But this one, this person has plaque. This person has an atherosclerotic plaque. So those LDL molecules have snuck into the endothelium. And while they're there, they have caused inflammation. When they're there, once they go in there, the monocytes come in, the macrophages that come and try to engulf it. And then once that happens, they start inflammation. The inflammation process starts, and you have all those inflammatory cytokines that come in there. And once those LDL particles come together, a lot of them, they form these foam cells. And then these cells start getting bigger and bigger. And then they grow to a point where they can literally occlude the entire lumen. So look at this beautiful lumen on this other side, but look at this one now. This is a blockage right there. And depending, you have blood clots now forming on there. These blood clots can dislodge, go anywhere else, cause a cardiovascular event, cause a DVT, cause hemorrhagic strokes and everything. So we want to make sure that our arteries are looking this way. And the only way is to try to reduce our LDL molecules, to try to reduce the total number of particles or the sizing of the particles, which is something which is very difficult. So we technically always measure let me move to the next slide. And you'll see what we look at. So when you come at cardiovascular risk, cardiologists will kill me for simplifying it, making it this simple. But I think this is the best way to look at it. If you get nothing from my presentation today, look at the fact that I have put cardiovascular risk into two sections. 50% of the risk is coming from your traditional lipid panel, which is your HDL, LDL, triglycerides, your total cholesterol, your VLDL, and the ratios between that. The other 50% is coming from your Lp(a), your Apo B, and your homocysteine, as well as your high sensitivity C-reactive protein. That's what I want to talk about today. This other 50% that nobody really talks about. The Lp(a), I'm going to go into detail. The Apo B, I'm going to go into detail. I only have 1 hour. We have 30 minutes to chat and some questions afterwards. We cannot do all 4. So this could be a presentation for future, or you could research it. Number 3 on this side, the HSCRP, that stands for high sensitivity C-reactive protein. That is a direct measure of your level of inflammation. So we talk about inflammation, and if you've heard me talk before, I talk about inflammation being the root of all evil in chronic disease management. And so if I say, oh, I'm inflamed, or I have inflammation, or, people with rheumatoid arthritis, all the people with inflammatory disease or autoimmune diseases, they usually show up with high sensitivity with a C-reactive protein level very high. So we can treat this with supplements. We can treat this with pharmacotherapeutic agents. And so that's not the only measure of inflammation. There are other measures of inflammation, other biomarkers that indicate generalized body inflammation, but C-reactive protein is your number 1. So there are 2 tests that can test the C-reactive protein. There's just one which is C-reactive protein. There's another one which is high sensitivity C-reactive protein. If you have to tell your physician to measure your level of inflammation, ask for the high sensitivity C-reactive protein. Don't just do the CRP. So there's a test that just says CRP. Don't do that. It's not as accurate as the high sensitivity C-reactive protein. The name literally tells you. The next thing that I want to just give you a brief introduction about before I jump in is the homocysteine. So your homocysteine values, you will see it abbreviated on lab tests as HCY. Your homocysteine is a biomarker, it is regulated by your B vitamins. So B as in boy, your B vitamins regulate this homocysteine. High levels of homocysteine, any level above 10, I consider it, this is my personal opinion, don't quote it anywhere. This is my personal opinion. If your homocysteine is higher than 10, be careful. But the labs want your homocysteine to be, so 13 is the number. When you have 13 and above, they're like, that is a high risk for cardiovascular disease. And that is also a high risk for early onset dementia. So that's something that I routinely measure at my pharmacy, the homocysteine, and that is an easily adjustable biomarker. If your homocysteine is high, you take a high level, like a methylation synergy, a high level B vitamin, it knocks it down. So if you are one that you have a genetic predisposition to have high levels of homocysteine, what you want to do is constantly be on a B vitamin. That's why people who are normally on a B vitamin, a methylated B vitamin, they normally have low levels of homocysteine. So that's just it's a very easy biomarker, easy way. That's why we say people for memory, for cognitive health, you throw people with methylated B vitamin and a fish oil, kind of reduces inflammation, kind of increases cognition for people who are elderly. So that's the 2 about that. And then we'll go into what we're talking about today. So you guys know, do your calculation for ASCVD risk, coronary heart disease, and you look at your peripheral artery disease. you also, something that I'm not going to mention in this presentation is your coronary artery, your coronary calcium score. So your calcium score is one test that we should be doing. So if one thing that I also want you to get from this presentation is that if you, after this presentation, say you go and do your Lp(a) test and your Apo B test, and those come out high, your next step should be to get your calcium score. So your next step should be to get your calcium score, just so you have an idea, because I'm going to go back to that. Let me see. I'll go back to this for a second. So in this foam cells that are here, so imagine this plaque is already there with all these inflammatory cytokines and the LDLs and all the macrophages and monocytes that are accumulating there to make that bigger. Imagine that we had calcium accumulated in the inner sides or in the sides of our lumen inside here. So if you have a high calcium score, that just means that there's calcium deposited inside your arteries. And that's why you guys heard me in the presentation I talked about at the conference I talked about vitamin D3 with K2. And K2 helps to prevent calcium. There's no calcification. This is a pure clean diagram, and I was not focusing on calcium here. But if this person had calcium, you would see calcified arteries. You would see it's literally a mineral. You know, you would see calcium added to this. So that just increases the risk of blockage for your lumen if you have calcium. And the way to reduce calcium in the arteries is to take vitamin D3 with K2. So anybody that comes already with a cardiovascular event or has a blood clot, I usually give them a higher dose of K2. So normally I take vitamin D3 K2, which is 5,000 units of vitamin D and 45 micrograms of K2. But anybody who has had a cardiovascular event or has had osteopenia or osteoporosis, I give them a K2 max. So I give them 180 micrograms of K2, which kind of reverses calcification in the arteries. So that way the artery can look nice and clean, no calcification and no foam. So the K2 doesn't really help with reducing the cholesterol, but it kind of helps with removing calcium from inside the lumen. I hope I explained that well. I cannot see a lot of people on the screen. I can only see a few people at a time. So if I ask a question, I might call your name to see if you're understanding what I'm talking about. So I think I talked. So I want to give a few definitions before I go ahead. So we talk about LP, so it's a lipoprotein. So think about it as, so our blood is, it's, it's water soluble, like it's water flowing in our arteries. So to carry fats in them, you have to bind it to the protein, like fat is water, and that's very basic stuff. Should not be talking to pharmacists like that. But think about it like your LDL carries the cholesterol inside. It carries triglycerides and cholesterol inside. So your LDL molecule, I have a picture and I think pictures do it so much justice. But when you think of Apo B are particles which are on every single LDL. So every single LDL in your body, every single LDL particle has an Apo B attached to it. It's like a hat that your LDL particles carry. So your LDL, your VLDL, your IDL, all of them carry an Apo B. So the question is, why then some people have higher Apo Bs and some people have lower Apo Bs? Let me define Lp(a) before I move it down. Then the other thing with the Lp(a), this is basically like a genetic curse. So if you get the gene, it is 90% genetic. There's nothing you or I can do to determine this number. By the time you have celebrated your 6th birthday, that is 6 years old, 5, 6 as a child, your lipoprotein a number is what it is going to be for the rest of your life. So this is 90% genetically predetermined. So your Lp(a) 100% just determined, but your Apo B is determined by particle sizing. So to test your lipid panel is one thing. To test the particle sizing is another thing. So we go one step further. Cardiologists will do particle sizing. I'm gonna go down the next. I think that's a repeat, just to give you a little bit of clarity on the slides. But then this is all common knowledge: diet, exercise, smoking cessation, weight management. This is common knowledge to manage the lipids. We'll go one step further, and then to help, we'll go one step further into when this is for primary prevention. As we go further down the chart, I don't expect you to look at anything in this chart. It's usually cardiologists who look at the C-reactive protein down there where I highlighted it. with the red, C-reactive protein, L-pillary A, Apo B. So that's why the average person doesn't get these measured. You have to have had a heart attack or two before you meet an advanced level cardiologist before they start testing things like this. But my goal is, can we make this standard of care? Can we bring this down? Because these tests are very affordable, and there's no reason we should reserve it only for people who have had a cardiovascular event and we're trying to prevent a second cardiovascular event. You understand what I mean there, right? So we need to bring it down and make it more affordable, and so that way everybody can have it. Like I explained, the Apo B is stuck onto our LDL levels. I'm going so I can see I was just writing this so that way, if you're looking at the slides and I'm not there, you understand what it is. Let me show you that traffic jam analogy. I like to describe it with a traffic jam. So look at these. These are your LDL molecules, right? So these are LDL, and to measure your LDL, we want your LDL to be 100 or less. And you look at some particles are bigger, some are smaller. So that's when we measure particle sizing. So imagine that somebody had these type of particles, this type. That person will have bigger particle sizes and they will have a chance to have lower Apo B. But if somebody has this type of small particles, you have a chance to have more of those because they know it's not just the so atherosclerosis is driven by particle number, right? So particle sizing, and you have smaller particle size, those ones that are like golf balls, they have an easier chance to enter that endothelium. But if you have big fat LDL levels, they cannot penetrate that endothelium and cause that atherosclerosis and start that inflammatory cascade. So you want your cholesterol molecules to be big and fat and nice and fluffy like this. People call them big and fluffy, but they're just big, and so they're not as dense. So we'll call them like low density lipoprotein. Move to this next one and see. So look at other countries in Europe. They measure the Apo B, the L-pillary A at least once. In Canada, it's recommended that it's a recommended metric for recommendation, but in the United States, less than 1% of people get tested every year. Less than 1%. And this test is affordable, as you will see. You'll see it in my final slides. So Apo B testing is something that I'm trying to see here. Let's see, I'm gonna move ahead a little bit. So now I'm talking, when I talk about the guidelines, we don't really have standard guidelines for Apo B and L-pillary A because there's really no medication that is really technically approved for L-pillary A and Apo B right now. There are a few, I will show you on the slide, which are in phase 2 and phase 3 clinical trials right now and very soon. And the reason why this was very passionate, I'm very passionate about this. When Dr. Carol called me and said, can you do a presentation for CAMPHA for the education series? I was like, yes. The reason why I'm doing this is because I personally have the gene for L-pillary A. And that's why I'm so passionate about this. That's why I went down this rabbit hole of trying to study it, because I was trying to bring down my own L-pillary A. So on the process, over the past 7 years, I've learned a lot about this to be able to bring down my own levels. And then that's why I'm teaching people about it. So about 90%, 90 milligram per deciliter is where we're, kind of okay. Anything above that. I've seen patients in the 200s, 300s, 400s. Or for L-pillary A. And that's really, those are the people who are just waiting to have a cardiovascular event. So anything above 130 is considered a very high risk for Apo B. And I think we move this on this other side. I think this shows it. So every single, like I said, all your LDL have an Apo B on them. So the question is, how many LDL do you have? Do you have tiny little LDL, which have more Apo Bs, or do you have big fat LDL, which have less Apo B on them? So that's kind of how the particle sizing falls in with the. So the difference between Apo B and L-pillary A is that L-pillary A is an additional, like a Kringle structure on top of your LDL. So think about that Apo B like a hat that every LDL molecule wears. And then think about the L-pillary A, which is a genetically predisposed. So this green L-pillary A here, thank your parents for it. Parents, grandparents, they gave that to you. Some people's LDL look like this, and some people's LPA, the LPA now is this particle that it's attached to it. They attach a small, it's an Apolipoprotein A protein, which is coded for that, is attached to that molecule. And this is what causes the danger, that little green stuff that's attached on there. So LPA is, like I say, it really affects Black people, people of African descent, and South Asian people. predominantly. So it just stacks the risk for these people. So that's why it's like, if you have Caucasian people, we could, take care of that. But for Black people, the risk is always higher. Every time you test a Black person, it's 1 in 5 people in the world. So on this, we have 40 of us on here, 1 in 5 of us have elevated LPA gene. So, and that's why I really want to encourage you guys to measure it. So 30 for LPA is considered, anything above 30 is considered high. So we want that LPA to be as low as possible, the LPA when you measure it. So let's go here. So like I said, because it's genetically determined, lifestyle will not really change it. So exercising, diet, and a lot of things. And there's actually studies that have shown that statins can actually increase LPA, which is really unfortunate, because the statins are helping the other part of the equation, but statins can increase LPA, but not significantly. So don't want you to be scared about that. But statins are not in the I'm missing something on here. So right now, the medications that they're not, so your doctor cannot prescribe Repatha to you for reduction of LPA unless you've had a cardiovascular event. A lot of people who benefit from this are people who are a second-time cardiovascular event, but most of the time, people, if you take Repatha, it brings down your Apo B by about 40%. So, and we know that's an injectable. Praluent as well. Those are the top 2 that really help. Juxtapid is also, but it's something that I will not want anybody that I love to be on Juxtapid, because it can cause, hepatic stenosis. It has, I think there's a black box warning on that. So strict liver monitoring increases your liver enzymes like crazy. So it's not something that it's fun, and most insurances don't even pay for it. But Repatha, with a prior authorization, you should be able to get it covered. So statins can help for Apo B, not for LPA. So I just combine them so I don't have too many slides. Zetia is the least effective of all of them in terms of pharmacotherapy. Let's go. And then let's talk about supplements. So supplements, and you would see the percentages. So supplements are not as effective, highly effective for LPA and Apo B, but taken over time, consistently, they'll be able to bring it. So I have not taken any pharmacotherapeutic agent for my LPA, but I've been able to bring it down. The first time that I measured my LPA was about 8 years ago, when I found out about this and started studying about it. My LPA initially was 73, when we want those values to be less than 30. So as we speak today, the last time that I measured it was last year, and it was 21. So even though it is 90% genetically predisposed, and I've not taken Repatha, I've not taken Praluent, I have been taking supplements to cater for this. So that's why I don't take a multivitamin. I don't take I take vitamins that are targeted towards what I am personally suffering with. So I know that I am bringing down my genetic, because, and then here's the other thing that I really want you to take note of. So I think I was just spying on my time to see how we're doing. And I want you to take note of the fact that when you meet a pharmacist and you're looking at cardiovascular, like lipid levels, when we measure your traditional lipid panel, we take a look at your LDL levels. We say, okay, yes, we want your triglycerides to be less than 150. We want your total cholesterol to be less than 200. We want your HDL to be anything above 60. We want your LDL to be less than 100, right? But for somebody like me, who has the LPA gene, and for many of you on this presentation who probably do have that gene but have not been tested and don't know it, we are going to hold you to a higher standard. So now, instead of just leaving my LDL that, I want my LDL to be 100 or below like everybody else in the world. So the cardiologists turn up the notch for people with an LPA value which is high. For us, my LDL guideline, my LDL goal is to be less than 70. So you see what we're doing there. We're holding my LDL to so that we're reducing my risk of a cardiovascular event all possible ways. We're attacking this side and attacking this side. So that's why, because this is very personal to me. So I make sure that my own LDL doesn't go above 70. And we're not, people are like, oh, cholesterol, very, very, we need cholesterol. We need cholesterol for some things, but we just don't need too much cholesterol. An LDL of 70, it's totally fine. There's plenty of cholesterol with an LDL of 70 because that LDL carries triglycerides inside. It carries all your phospholipids inside. So LDL of 70, that's my personal goal. And you can make that your goal if you know your Lp(a) level. So that's why people are like, oh, it's genetic. Why do I even need to bother about it? Because there's a lot of things that you can do, even though people just say, oh, it's genetic, and we're not worried about it. I added something to a slide, and I don't know that I could see it here. I will put it in the group chat. There are 3 medications which are in clinical trials right now for Lp(a) and for Lp(a), and these are mRNA, the short interfering RNA clinical trial phases, and these are going to be injectables. So I don't know that I want to do an injectable every month if my Lp(a) is controlled. So if my Lp(a) was not controlled, absolutely I will get on that injectable. But personally, I will probably wait for like a year once it's out to see how it does to be able to before I get on it. But currently, my Lp(a) is not at a place where I need the injectable, but I'm following the clinical trials very closely just so that I know what's going on, and they should be available here. There's a Picalcerin, and there's one which is called SI, and I can't remember it. It's like a clinical trial name, and you know how funky those names are. So, what else? Yeah. So I have patients. So I had a patient. Let me see here. Move this here. So these are just individual studies that, like my own patient. I had a patient who came in with Lp(a) of 221. And I told you that we want this level to be 30 or below, her Lp(a). So in 6 months, I put her on niacin, I put her on CoQ10, and her levels dropped to 130. Nowhere near we want it to be. I immediately, with that Lp(a) of 221, I sent her to a cardiologist immediately. Okay. I sent her to a cardiologist immediately. And I said, so anytime I see an Lp(a) of 70, I'm like, here, go to your cardiologist, get a calcium score. Tell him immediately that you got to your pharmacist. And the cardiologist said, hey, that pharmacist might have saved your life because you're anybody walking around with this number, it's just waiting for a cardiovascular event to happen. So it's just chance. Yeah. So, and she's really grateful. She is on her CoQ10 and niacin every day. Niacin, I'm very cautious with. Niacin is one of those supplements that once you give patients, you got to be careful because they can increase liver enzymes as well, but they really do well and then they can cause flushing too. So, and a lot of my patients are perimenopausal patients, and they, have a tendency to have already hot flashes from menopause and perimenopause. So, what else is there? I think I repeated that slide. So what could we do as pharmacists? I hope that this was like educational, just bringing out some things from the lifeline to you so that I want you guys to get tested. So you guys know that this is what I want you guys to do. So like when I talked about vitamin D, I was like, you cannot be my friend if your vitamin D level is less than 70. You want to test it so you know your vitamin D level so you can take your vitamin D. Like when I talked to you guys at the convention, test your vitamin D levels. Don't say my vitamin D level is within range. When somebody says, oh, it's like my cholesterol is within range, nobody really cares about that because your Lp(a), your Apo B, your homocysteine, your C-reactive protein, these are for cardiovascular disease. That one slide that I showed that had 50% your lipid panel on one side and this other 4 markers on this side, that's the one slide that I want you to take from this. Okay, so test and figure out. And then I've been working with Fullscript, and we have a testing platform, which I had mentioned that I was working on when I presented to you guys. And it should be live as of in the next week or 2. You should be able to. So I've been using it already from October. I've been using it, but it's about ready for other providers to sign on. So I'm very excited to share it with you guys, but I want to show you guys what I'm doing at my pharmacy. So at my pharmacy, this is what I do. So I've partnered with Fullscript to put this together, and I do tests like biomarkers, so core wellness and 66 biomarkers. Some of you have seen this Function Health ad where Dr. Mark Hyman is testing 100 biomarkers for and people are testing it, and then you get results. But here is exactly what I'm testing. The biggest one with 125 biomarkers also tests hormones. But if you scan that QR code, so what you could do if you're interested, so in addition to, so my goal, I had 3 goals with this presentation today. give you guys the education so you know what LPA is. If you didn't know, at least you know what LPA, you know what Apo B is now. You know that something exists out there like that. Second, you could test it for yourself. So by being my patient. So if you want to test it for yourself, you could be my patient and test it. And that's really optional for you. So let me move this to this side. So if you scan this QR code, up here, you can log on and do this middle test. This middle test will test 88 different biomarkers. And after you get that test done, then you sit down with me. I do a virtual meeting with you like this, and then I go through all those biomarkers. I tell you the supplements that you should be taking to be able to bring those biomarkers into place. And this middle test does cover that LP(a), Apo B, C-reactive protein, and insulin. It tests about 88 different biomarkers. The reason I'm not recommending the big one is because that has hormones in it. And so that's the one I do for my perimenopausal women, because I do have an OBGYN partnered with me at a pharmacy that she does all the evaluation for that. So we do that for all my patients. You could do the big one if you're interested in knowing your hormones, and we can work on that. But what I recommend for you guys is, if you're interested, you can scan that QR code. If you click on it to find out the test, it's HSA eligible, FSA eligible as well. So if you want to do that, you can go ahead and do that. But the next part is you becoming a Journeys provider. Okay, so you becoming a provider. If you scan this QR code right now, it's not yet live, but my goal, if I achieve nothing during this presentation, is for you guys to scan this QR code, and I will also text the link in the chat. Scan this QR code, put in your first name, last name, and your email. When it's live, I will send it to you, and you will become a provider. You will be able to test yourself. You will be able to test other people in your family and your patients. But my recommendation is, if you do it as my patient, I will be able to go through the results with you, and then you'll be able to know how to be able to take care of other people. So totally, I think that's really all I have for you today. And some references, and I think, yeah. And here we go. So that's it. I'm going to put the links in the chat, and then, but we can get back to chat, and we have, how many more minutes? I think I did okay. Venice, what do you think? Carol? On time.
You're doing fine.
You're doing
thank
good.
You so much. Thank you so much for all the information. I was trying to write things down, and at some point I was like, if I write, I'm going to miss the information. So thank you for also allowing us to, accepting to share the PowerPoint with us, because it's a lot of them.
I know. Sorry, I did a lot of writing in the thing so that way people can just, because I want people to get information. Are there any questions? Did they put any questions in the chat? I wasn't looking at the chat. So
yeah, and I can read them to you. You don't have to worry about it. So the first question says, what can we do to make these testing standard of care? Can we request of providers to order them, and what about insurance coverage?
Oh, yes. I knew that question was going to come. So the first thing is that our healthcare system is not set up for preventive medicine. A healthcare system would rather wait. You see how many people have tested? It's 1% of US population who have been able to do an LP(a) test. So if you finish this presentation today and you go to your primary care provider and say, can you test my LP(a) or your Apo B? They will tell you that that's something which is usually reserved for cardiologists. So your cardiologist can take care of that if you have higher risk. So most insurances will not cover it unless you're determined as higher risk before they will cover it. But guess what? I charge $389 to test 88 different markers. Think about it. And LP(a) is among, Apo B is among, all your lipid panel is among. The previous slide that was there, right? So those 88 biomarkers, your thyroid hormones are in there, particle sizing, your omega check. I can't even tell you. Oh, no, I did not mean to do that. Yeah, I can't even tell you. So, but cash price, if you were to go, like, say, if I were to order this test for you, it will be something like maybe less than $40 if you were to pay cash. So, but your doctor will not even want you paying cash for it, because in order for them to order it, they need like a diagnosis code. You know how the medical system works. So, and it's just like trying to go change politics from the White House down. We try to change politics from the grassroots. So that's kind of how it works.
Okay. So overall,
does that answer the question?
I think unless the person has a follow-up question, but my follow-up question with that was, in general practice, what would even prompt like practitioners to go ahead and want to order those? And I think you kind of answered this, but I have, like, personally for me, I've heard about them after my residency, but in pharmacy school or anywhere else, I haven't heard about it. So I'm like, if I go to my doctor and everything is fine, in what circumstances would my doctor be like, hey, we need to look at these other cardiovascular markers, basically?
It will be if you have had a cardiovascular event, right?
So I get one before.
Most of the time, I won't see. So you saw that statistic that I put there, that only 1% of the US. So even when people have a cardiovascular event, doctors don't even go deep that way, because in our guidelines, the doctors, if I'm a cardiologist or a primary care provider, I do the tests I follow a guideline. I follow the hospital policy and procedure. When somebody comes in, you do this test, you measure it. If it's this, you give this. If it's this, you give this. Lp(a) and Apo B are not in that guideline. So nothing really prompts them to measure that, because there's nothing to do after they measure that. Does that make sense? But right now, after this, you will see in the next 1 to 3 years, once those medications come out, and I will put them in the chat. Once those medications that are in phase 3 clinical trials, once they come out now, then you will see these be incorporated into guidelines now. But think about the number of people who are having cardiovascular events prior to this.
Yeah, and like you say,
yes,
especially when it's like targeted to just like a specific patient population, so it's even harder.
Yes.
There was a question from Carol, and she's asking, are the current risk calculator adequately calibrated for African or African descent population when Apo B is incorporated, or are they underestimated of our risk? Not sure if the question is.
If I understand the question very well, it's like, okay, remember how we do, like, when the calculate kidney, when they are like kidney calculations, they used to incorporate, I don't know if they still do. Do they still, is there a nephrologist in the room, like do they still incorporate, like, take into consideration race in the kidney calculations for glomerular filtration rate? Think about, remember that? Does anybody remember what I'm talking about?
Yeah, talking about the Crocroft equation to do
exactly. Yes, that's the name I was thinking about. They incorporate race into that, right? But we don't know when Lp(a) comes up. I don't know, are they going to incorporate race or are they not going to incorporate race? I don't know. So, but we cannot be waiting for the general population to take care of us. We start taking care of ourselves, and then we advocate for them to incorporate race into it down the line, because there's going to be a lot of research there's going to be a lot of research on it. And then, the other thing is that they will have to enroll a lot of our people in research studies before they truly say, okay, this is really significant. Let's incorporate race into that equation or into the guidelines. If a Black person comes in with a cardiovascular event, let's go ahead and do their Lp(a) or let's do their Apo B. We don't know how we have to really advocate. And our people, we don't sign up for clinical trials a lot. They have to push us, because we're looking at it like I'm very skeptical when it comes to clinical trials. So that's kind of how we look at it. Yeah. So this is going to be grassroots effort. So we're going to measure ourselves and take care of the people. And you see, for me, because I did this, I measured all my children. Okay. I measured all my children, because if you have Lp(a) gene, you have 50%, your siblings or your children have a 50% chance of having that gene. So that's kind of how it goes. And then now I know that, hey, my son already takes a CoQ10. So, and that's, so I know, I go, Papa, you're going to have to take a CoQ10 for the rest of your life. Yeah. So that's basically it. So if it's one supplement that he has to take, it's going to be that. So, and that's going to be gradually taking that. So think about it. If he has it, he takes a CoQ10 from now till when he's 80 or 90, and then somebody else who never gets tested, think about how much that CoQ10 or that niacin is going to reduce his level over the next 30, 20, 30, 40, 50 years of his life. So it's being like very using our knowledge into practice. Like instead of using this knowledge and be like, oh, $389, too much for me to spend. But $389 of knowledge that you're going to use for the rest of your life, because you don't have to measure that again. Unless you're if you measure it and you don't have the gene, kudos to you. Bless you. I wish I had your genes. But if you have the gene, then you act like me. You go ahead and take CoQ10 every single day. I don't travel without it. It's like I just came back from Canada for a speaking engagement. There's one thing in my purse, it's CoQ10. I don't go without it. Yeah. So I'm just very targeted like that. So it's not because there's 50 million supplements, I'm going to take 50 million supplements. I take what is important to me. Okay.
Good question.
Yeah.
So you mentioned that it's a concern for the Black community.
Yes.
The Black prescriber or providers, how are they looking into this? What's the concern? If you say it's more so of the Blacks, I mean, I would think there's a Black provider association. Do you think it's something that's of concern for them? If you know that it's mostly the Blacks, and how are they not, raising the alarm? Making sure that, because if you look at the lab orders, like you mentioned earlier on, yeah, you have the C-reactive protein, you have the homocysteine, but the LPA and APB, Apo B is not there. So why is it that the Black community, the providers, are not raising an alarm on this? It's just a concern. If we think that it's really affecting our Black community, why is it not something that the Black providers, are raising that as a problem?
I think personally is because once you start to advocate for something, you have to have a clear-cut solution for it. And so think about it. If I was a primary care provider, I would start by taking care of my patients. So think about if I'm a cardiologist, I would test my entire family first and start taking care of them. You cannot go and be fighting a war at the national level when you have not started the war in-house, when you have not started fighting it in-house. So that's kind of how I look at it. This is my personal, and I cannot speak for the Black or the American Black Cardiologist Organization. So I don't know what they're doing. I don't know, but there is a link to test lipoprotein A free, which is given by the company that is doing I think it's pilocarsen. One of the drugs that is in clinical trial, the company that is working in it is doing a clinical trial. So to raise awareness, so people start testing so that when the medication comes out, people will know already. Yeah.
Thank you.
So there's awareness coming. In the next 1 to 3 years, you will see a lot of Apolipoprotein B, and eventually it will come into standard of care. But I just wanted to let you guys aware, because I am like a little bit knowledgeable on it because of my personal history. Okay. Yes, I see a lot of hands.
Yeah, and I think we have one of our colleagues that actually posted a link that might be connected to what you're just saying, free lipoprotein test for free if needed. And I think it's Engine that is supporting that. So I'm not sure if that's what you were just talking about, but
yeah, I could. If somebody else, I have the link and I can post it. So that one is just Apolipoprotein. That's lipoprotein A. That's just the test. So you could do that one for free, but I recommend getting the whole bulk thing, getting your C-reactive protein, getting your homocysteine, getting your Apolipoprotein B.
Okay.
More questions?
Let me see how we're doing on time. So we have 6 minutes. So I know Dr. George Lehman, you had your hand raised. Are you okay? Has your question been answered, or do you want to go ahead before I take Dr. Renadine?
We can proceed.
George, what's your question?
You're
not going to do that. George, ask your question.
It wasn't a question. It was one to say, yes, Amgen has been leading the charge on Lp(a) research. And to the point why we're not testing this now, when statins came to the market, we thought we had fixed cardiovascular conditions. Until we have used statins for years, and people are still having cardiovascular outcomes. And so the scientists will go back and say, what are we missing here? And that's how Amgen started looking at what else do we need? What are we missing in this picture? And now we're going now further down to see what in that cascade. So that's all I wanted to share.
Thank you very much.
Good.
Yes, and that, yes. See, thank you, my brother. I'm happy that we're on the same page. So, and what was missing is that whole 50% on that other side, that Lp(a) and this Apo B. 5-10 years from today, it will be standard of care. But we don't want to wait. How many people are going to have a cardiovascular event? One of my classmates from CPC Bali just died out of nothing. And I'm just thinking, cardiovascular disease. They probably had a cardiovascular event, but their cholesterol is probably fine because they're probably not on the statin. You talk to the family, they were just fine yesterday. Yeah.
Okay.
Any other questions?
We have one or two more questions. So Dr. Rendine, do you want to go ahead and proceed with your question?
Thank you so much, Dr. Venice. I mean, it wasn't even a question, it was just a comment. First of all, thank you, Dr. Tubuo, for this great presentation. Thank you also for all the great questions and so on. But I just wanted to make a comment from what Dr. Senwu was asking, and I think you answered that already. I think awareness is one of the biggest things, health equity, because to fight for the African American community, we have to be involved, we have to be educated, and education is a big part of everything that we are missing into this picture. And when you start talking about clinical trial and other things like that around our people, they tend to be very reluctant. I mean, for obvious reasons, we know the history in the past, right?
Yes.
But now that we know a little bit more and we know how everything is conducted on the research side, we need to be able to educate our people to understand the benefit of it, because if we are not part of those clinical trials, the results is not going to reflect, our community very well and those kind of things. So it was just to kind of add a little bit on that. Another question, but thank you so much for the great presentation and comment.
Yeah, and to add up to that, I remember back a few years, I did a presentation on like the medication, how they affect the different populations, and I was able to find actually that even the medication for the malaria that we use in Africa, when you look at the effectiveness, because it was just in a certain population, it was working at 77% in European descent population, but in African descent population, it was only at 44%. But because when the clinical trials were going on, it was mostly European, it was just marketed for everybody, but effectiveness-wise, it wasn't really working when we looked at subset. So it's very important to be involved more in research. I'm a research pharmacist myself, so I always try to involve my patients in the clinical trials that are going on at my side of practice. I had one last question for you. So you talked about the fact that when you knew you had the gene, 50% of chances that your siblings or your children are going to have it, so you started your son on supplements early on. The fact that he's starting to manage that part, does that affect the percentage of passing down the gene to his kids, or is it just management at his level?
From scientific perspective, that is not going to affect that because the CoQ10 is not affecting the mRNA. Because his genetic predisposition is kind of set. But you know about epigenetics, and you know about turning on the genes that help us, turning off the genes that don't help us. There could be a chance that could be. I cannot answer that question with 100% certainty, but I know that I am affecting the chances of Lp(a) affecting his cardiovascular health in his lifetime. So we start from there, and then we go down the line, and then we are aware by the time he's having children, maybe it will be standard of care. Maybe the siRNA, the siRNA therapy will have come into play. So, but before we close, we're at 5:59. I appreciate you guys. Thank you guys for being here. I love doing stuff on time. I love doing stuff like this. I feel so elated to be able to share this knowledge with you guys today. But here's my plea. The general thing, I know my people. I talk to Cameroonians all the time. I talk to my own people. I talk to Africans all the time. I talk to African Americans all the time. I talk to Caucasians and Asians all the time. Here's what happens. The difference between our people and other people is follow through. We get the knowledge, then we sit on it. We look at our dollars and we prioritize our dollars in the spaces that do not affect us down the line. We invest in the things that will make us look good to other people, that don't really matter to us. The chances when I do this presentation, I'll do this presentation in, maybe 800 people in front of me, Africans, African Americans. You will have 1 or 2 people test after this, but they get the knowledge and they're acknowledging it. They're looking at it. Oh yeah, I know that Emlah talked about that. Oh yeah, but you do this same presentation in an environment where they're Caucasians. You have about 70 to 80% of them testing on the same day. So education and proximity to knowledge is nothing if you don't take action. It means zero. So having this knowledge, banking it somewhere in your head where the same like the people who are walking in the street who don't even know what LP-A is or Apo B. So do yourself a favor and test it for yourself. I've already done that for myself. Everybody on this forum is a pharmacist. $389 is a piece of cake to get knowledge about yourself. It's like testing the Apo E gene for Alzheimer's. I went ahead and tested it for myself and my entire family because we can afford it. Because we have a vacation we can take them to Florida, taking my son to go and watch an Arsenal game. We're spending 10 times more money on that, okay, than doing all of this. So I want you to balance your life and put money where your worth is and where your brain is. So do the test for yourself, become a provider so you can test your family. Once you become a provider, if you do the test on me as a patient, I make like $100 on it. I could make way more money on that doing my speaking engagements. But if you become a provider, you make like $100 when you test other people. So, and all of it is free. You pay nothing to become a provider. So that's how I work with Fullscript to be able to give this. So my role at Fullscript is a pharmacy KOL for Fullscript. So my goal is to bring pharmacists on to be able to become a provider, to be able to do these tests for other people and educate people. So people cannot start taking a medication where they don't know what's going on. So do yourself a favor. If you want to get all the things, test yourself first, like my patient, and then I'll sit down with you, explain the results, make supplement recommendations. You can take them if you want. You can buy the supplements on your Fullscript account if you want. Or and also sign up to become a provider in the next few weeks. All of you can become providers and you can test yourself, you can test your family members and discuss. And I can have like talking points and like a 1-page protocol that you could use for this. And my work is done.
Nice. Thank you so much. And I'm going to need you to repeat that quote that you say, awareness and education, because we really need to put that on the banner and like just put it everywhere because it's very, very true. So thank you again for your presentation. I know we had one more question for Dr. Franklin, but we are 3 minutes past the hour. So if any of you guys have any other question, you can always put it in the chat and I can forward them to Dr. Emlah. Go ahead, Dr. Emlah.
Please, can I answer Dr. Franklin's question? I beg
Yes,
you.
Okay, go ahead.
Yes,
Thank
please.
you.
And before you go ahead, Dr. Tubuo, please, I just want to make one comment. Please do not leave the chat because after that question and after we close this, we have leadership will have a little bit of an announcement, and Dr. Marion Bonnet is going to be announcing that. Please do not leave the chat. So please go ahead and answer his question. Thank you.
Yeah, thank you. I want to answer my brother's question, but here's the thing, huh? So I'm gonna stay on. Our meeting is officially over, but I like to stay on for the after party. Okay, so I'm gonna stay here, and if anybody has any questions, I'm willing to answer because I have nowhere to go for the next 30 minutes. I'm here, so I'm at home. So.
Hey, thank you so much, Doc. Can you hear me okay?
Yes.
Thank you for the great presentation, and it's always a pleasure to listen to you teach us. I just had one question regarding when you mentioned Juxtapid. I started shaking on my chair because when I started working for ProPharma Group, that was one of the products that I was working with, and had a little bit of my interest in cholesterol, and at least it's a limited. It affects a few people, but it's kind of surprising that you brought that up. But I don't see that it is approved for for LPA.
No, it's not.
Is it being used in that field and as off-label? And I know, of course, one of the biggest side effects that I used to hear every day was about diarrhea. Every day I would listen to side effects of diarrhea, and I felt like my job was talking to people about their diarrhea. So why is it, in this case, being used for LPA?
It's really not being used for LPA. So why I put it on that slide was because it has been proven to bring down LPA levels. So just because it's been proven to bring down LPA levels doesn't mean that it's going to be on the formulary. If pilocarsen makes its way through, it can bring down LPA levels by like 80%. So the slide that I emailed to Venice, so Venice will share those slides with everybody. It has the updated, I put in the 3 medications that are on clinical trials in there. You will see on that page. So Juxtapid is, the chances that it's going to be approved for LPA is close to 0. Not just for the GI side effects, but for the hepatic side effects. So it's the chances of that is going to go downhill because the new mRNA targeted therapies, they're biologics, so they're going to be very effective. They're going to cost a lot of money, but they're going to work. Yeah.
Awesome. Thank you. Thank you.
Mm-hmm. Thank you, guys. I hope that was fun. I don't know if to call it fun or I don't know.
It was great. It was great, Dr. Tubuo. Great presentation.
It was
great learning.
excellent.
Try to reinforce that taking action is a big part of this. It's not just about listening, getting the information, but we have to take action for ourselves and then for our loved one, and then the people that we have around us. You know, spread the word, educate, and take action. So that's what I think. That's what we need to remember then.
Yeah. And so we'll get the knowledge, then we'll leave and make other people take action. We should don't look place.
Yes. Okay, let me go ahead and I will stop the recording and then I will have Dr. Mbone take over.
Yes. I just saw a question. Sorry about that.
Oh, okay.
My testing, HSA eligible and FSA eligible. Yes. So you have an HSA card or FSA eligible and HSA eligible. Did a lot of work to make sure it is that eligible. So I'm happy about that.
Okay.
Well, thank you again so much, Dr. Tubuo, for
thank you very much. Yes.
Your knowledge, your expertise, for just always being willing to share with us and push us to action, because we cannot overstate the fact that all of this is useless without us taking action. So I've made my notes. I'm going to be talking to my doctor tomorrow. I was sitting here bragging about my lipid panel results, but now I know it goes beyond that, because we have had recently quite a few people, and I'll say, in their 40s to 50s, just drop dead. And we're wondering like what happened. And for the most cases, we know that it's been a cardiovascular event. So thank you for bringing that awareness to us. And I hope that we can also share that and also be encouraged to take action. So just in the few minutes we have left, I want to, Dr. Renaden, can you share that slide, please? Because I don't have co-host privileges.
Oh, you do? Let me give you that because my computer started having some issues with Adobe and Acrobat. So let me give you that. I'll give you the co-host.
Okay. We just want to take this next few minutes to just talk about our convention. A lot of people have been asking questions about the dates, and I'm sure everybody knows that it is in Maryland. I saw Dr. Sylvain, who is the DMV coordinator, on the call recently. And so we want to officially release the save the date, but it's a little more than a save the date, because it also, let me know when I have
Yeah, give me one moment here.
Okay. It's information to get you started. So if you need to take time off work, the hotel link is live, so you can go ahead and book your hotel as well. So our convention is going to be held in Maryland from October 8th through the 11th.
You do have the course now.
Okay. Let's see, share my screen. Screen this one.